A very good afternoon to everyone, respected chairperson sirs, my seniors, my colleagues and the August gathering here. And let me proceed with the talk on post-COVID eco-evaluation in children. This is what more or less our experience of all of us have experienced COVID in some way or the other. It pretty much sums up to this. And this is what is post-COVID state. So this is a slew of all the papers that I went through when I was searching for this kind of a topic. And there were authors like Matsubara et al., Feldstein and Murray, who I found these papers published in the international journals. And I found that in COVID, it's the main crux of the thing is viral tropism of the myocardial and endothelial cells, which leads to myocarditis, LV dysfunction, shock, arrhythmias, thromboembolic phenomena, and of course, the multisystem inflammatory syndrome in post-COVID in children, which is a doppelganger of Kawasaki disease in children. So, though in children it is slightly different from adults, because elevation of troponins have less dire implications in the children, it is maybe due to just a transient type of myocardial injury with preserved cardiac functions. And yesterday we had a wonderful session on MRI, and we saw that here in children, diffuse myocardial edema and hyperemia without evidence of focal myocardial necrosis or fibrosis is present in children, in contrary to that of adults. Of course, we all know that COVID can cause acute events even in asymptomatic patients without any pre-existing comorbid cardiovascular conditions. Now, coming to the holy grail of the post-COVID state in children, that is the multi-system inflammatory syndrome. And this is a case definition. Nowadays, AAP says less than 21 years, but according to our Indian guidelines, it is below 19 years. Children and adolescents who present with fever for more than 3 days, and any two of these, which may be simulating Kawasaki disease, like rash, non-purulent conjunctivitis, mucocutaneous inflammations. Many times the children present with hypotension and cardiogenic shock, features of myocardial dysfunction, pericarditis, valvulitis, and of course, elevated biomarkers. Coagulopathy and gastrointestinal problems may also be present commonly. Of course, we have to rule out other bacterial infections, and there must be presence of other evidence of either acute infection of COVID or the serology may be positive. So just let me walk you through a few cases which I found very significant related to this talk. There was this 14-year-old boy with past history of COVID in last 1.5 months. He was well built. He came with fever for 8 days, no rash, no other symptoms other than fever. He was quite withdrawn. And being an adolescent, I just thought that I would examine him in details, and I found him to be tachycardic, tachypnic, with a lowish BP. And when I did the echo, there was severe dysfunction, 30% or lower dysfunction. And this was my preliminary attempts at the global strain imaging. And the GLS came to below like -12 or -11%. So it was severely reduced. This child received IVIG and methylprednisolone, high-dose methylprednisolone, and with that recovered very dramatically. The recovery was so dramatic that there was 10% increase in ejection fraction and simultaneous increase in the strain patterns right in the evening when the IVIG was started, about 12 hours after starting the IVIG. And then in the next 2 days, the function returned to normal. And this was another child, 10-year-old, very overweight, with fever, chills and rigor, headache, vomiting and diarrhea, presented with tachycardia and tachypnea, low saturations, chest X-ray has diffuse opacities bilateral, very high NT-proBNP and COVID IgG levels. This child had normal function, but as you can see in the picture in the middle over here, I found the LAD to be very hyperechoic, and there seems to be some sludge in the in the coronary lumen. And there was a team formed, and the team decided that we will go with IVIG, methylprednisolone, and low molecular weight heparin. And in the lower part, you can see that this is the coronary about a week later. the subsequent coronary angio was normal in this child. So this paper by Dr. James shows that the strongest predictors of myocardial injury in MISC was global longitudinal strain, global circumferential strain, as well as peak left atrial strain and longitudinal strain of right ventricular free wall. Though the systolic function may recover, however, the diastolic dysfunction may persist, and this has got, right now at present, it has got a little bit of uncertain significance in children. And this is the comparative analysis of the long-term features, long-term dysfunction in the strain patterns in the normal patients seen in blue, Kawasaki disease in red, and MISC in black. As we can see, the GLS as well as the other strain patterns are significantly lower in MISC. This is another graph showing the rate of resolution of left ventricular ejection fraction in patients with MISC. We can see initial 7 days, the EF increases markedly and then sort of normalizes by about a month in most cases. In coronary artery aneurysm, however, it is a little bit of a slow recovery. And this another very pictorial depiction of the longitudinal recovery of the strain patterns. The GLS, the RV free wall strain and the LA strains, they quickly recover in the first 1 week. Then sort of it plateaus out and then slowly recovers about 2 months or so, 2 to 3 months. But in cases of early diastolic strain rate, it is a much slower and lesser recovery. So just to summarize the different studies that I went through, that even with preserved systolic function, subtle changes in diastolic function and strain parameters may persist, suggestive of some underlying myocardial injury. In short term, though, there is normalization of systolic function. And of course, this myocardial injury was evidenced by elevation in biomarkers, and there is minimal coronary involvement. This study was done by Dr. Matsubara. And in another study by Dr. Capone, it shows that cardiac MRI in select patients did not reveal any features of any myocardial edema or fibrosis. So that's a good sign for all of us. And there was persistence of diastolic dysfunction, though systolic function recovered. In most of the cases, 90% of the cases, by 1 month, there was recovery of systolic function, and in 80% of the cases, coronary artery aneurysms resolved in the study by Dr. Feldstein et al. So this is the crux of it, that we have to look for any dysfunction, systolic, diastolic, look at the strain parameters, see the Z-scores of the coronaries, look for any valvular regurgitation or effusions. And this is another interesting case, which was actually, this came out as a presentation in one of the conferences, that we are following up those with MISC. What about those children who had COVID, but then did not have any other features? They did not have any MISC. They showed that these children did not have any other problems, like no echocardiographic abnormality at all. So it's a very good news for all of us. And at the end, I would like to just discuss my paper on Kawasaki disease and multisystem inflammatory syndrome, which was presented in Association of European Pediatric and Congenital Cardiology in May of this year in Geneva, Switzerland. And in this study, we had found that there was a significant presentation with shock, coagulopathy, and severe dysfunction in the pre-adolescent children around 10 years, 14 years, and the adolescents also. Dysfunction seemed to be a prerogative of those beyond 5 years. We did not find a single case of cardiac dysfunction those below 5 years. Rather, those children had presented with coronary artery aneurysm or dilatation. And this is the comparative comparison of the differences in MISC and its doppelganger, the Kawasaki disease. There was significant male preponderance in MISC. Infants were less affected. Dysfunction significant over 5 years of age. And there was no significant variation in single or multiple coronaries. And we did not find a single large or giant aneurysm. In KD, however, there was more involvement of the infants, the more coronary, severe, and multiple involvement of infants. And we had 6 cases of large and giant aneurysms. So here we have the coronary involvement pattern in KD and MISC, the large giant aneurysm involving all the 3 arteries in KD. And in MISC, it was in blue. Here we see it is mainly mild dilatation or ectasia, and some cases were moderate. Interestingly, it is those cases with moderate dilatation of coronary arteries also, as is shown here in the lower part, those cases also, they needed infliximab. The fever did not resolve, and ultimately the child needed a second-line therapy. In Kawasaki disease, those with giant aneurysms, in those cases we had to use the second-line add-on like infliximab and all in addition to IVIG. So this is just strange coronary patterns that we had found. In the first case I had discussed, there was this coronary sludge initially in the acute phase, and within 1 to 10 days this was the coronary. Subsequent coronary angio was normal. In the second case, another a 14-year-old boy who had a little bit of dilatation of the coronaries, but clinically was very sick with bleeding from every side and shock and dysfunction. This child initially had mild coronary dilatation, but later on, at 1 week follow-up, had this kind of a blob in the coronary, which we did not find anything abnormal in the coronary Dopplers, but subsequently this disappeared on giving low molecular weight heparin. Subsequent coronary angio was also normal. In this child, which was around 4 to 5 years of age, there was initially a kind of a stenotic lesion in the origin of the LAD, but subsequently at 2 months follow-up, this was there, and the RC was a little dilated, and this child, they did not consent for any coronary angio, so is still on follow-up. But is MISC the end of the road? Like, we are giving such strong biologics, etc. for MISC, but what is going to happen after that? So this 2-month-old boy who had received IVIG because mother was COVID positive and he had rash and fever in the neonatal period in some hospital in eastern India. And this child came to us with fever for last 10 days and then suddenly collapses on the 2nd day of admission and had to be resuscitated. And when we did the echo, we found this large vegetation almost blocking the tricuspid valve and severe dysfunction. And this gradient across the tricuspid valve was around 6 to 8, and this severe dysfunction was also present. So this child didn't give us much time before he could be taken up for surgery. This child expired. So this is just a sort of a eye-opener that MISC may not be the end of the road at all. So this is my fangirl moment with the head of the Department of Pediatric Cardiology in Canada and Amsterdam, so in Geneva. So thank you very much to the organizers, and thank you very much everyone for my listening patiently.
Thank you, Dr. Debadatta Mukhopadhyay, for a beautiful deliberation, and you have shown us beautiful cases. Anybody, any question? You have little time, no?
We have got 2 minutes time. Now, Debadatta, you have shown some differences between the Kawasaki and this, but maybe it is easier to differentiate in the later phase. So, when do you think they carve separate? What do I mean by that? The coronary arterial picture starts separating from this to that. Both are viral inflammatory conditions.
Yes, sir.
Maybe in the later phase you can differentiate.
Yes, sir, I think the differentiating point would be a very high IgG levels, COVID IgG levels evidence. And the kind of, usually the KD cases we found, they didn't have such high IgG level or evidence of any COVID infection. And there may be a history of COVID infection 1 to 2 months back in those children where we are suspecting an MISC. In the adolescents, sir, we found MISC to be present like I presented in the graphs. Those around 10 years, adolescents and pre-adolescents, they presented with shock, dysfunction, coagulopathy, bleeding everywhere. They were intubated, ventilated, and the recovery pattern was like phenomenal. After IVIG and methylprednisolone, there was like a miraculous recovery. Within 1 week, they were walking, and they could be discharged in about 10 days. So I think in KD, we rarely found those kind of dysfunction, excepting in cases of KD shock syndrome, which 2 cases we had only. Coronary involvement, sir, KD in infants, we found to be very, like they were involving multiple arteries, and there was very, like either moderate, or we had a few cases of giant aneurysms also. In MISC, coronary involvement, though present below 5 years, but that was very mild, sometimes moderate. And those who were moderate involvement, enlargement that is around 5 to 10 Z-scores, they needed infliximab. Their clinical features like fever also didn't come down without giving the second line therapy.
So do you think they also require, like the adults, antiplatelet and anticoagulant, etc.?
Yes, sir. Those in whom the coagulation, there was evidence of thromboembolic, like I showed in case 2, evidence of thromboembolic phenomena.
I'm talking about prophylactic, not after demonstration.
Prophylactic, yes, sir. Absolutely. They are put on aspirin, long-term aspirin.
Any question from the audience? Be brief, sir. Yeah, please introduce yourself. Everybody may not be knowing you.
Now, my Dr. Jha, I'm Dr. B.N. Jha from Southeastern Railway.
Hello.
Basically, regarding the ECHO criteria for diagnosing KD as a coronary artery dilatation, because we are getting, and just the opening is very difficult to pinpoint the dilatation coronary involvement of this. What criteria are filling, and what the minimum of length then you are putting, confirming that it is a KD?
KD is a clinical diagnosis.
Yes,
first.
one is clinical.
KD is
I'm
a
just
clinical
echo
diagnosis.
echo parts. And
Echo-
what difficulty as a beginners, because one case only I have got it, and because next day with the help of our pediatrician we have started IVIG and responded very well. For whole things gone very smoothly. But on this echo forensics, I wanted to know what's criteria in your mind while seeing the patient, because then we can level
There
as a
are,
case.
I think, shall I?
Yeah,
answer?
in short.
There are definite echo criteria, like we classify the aneurysms as mild, moderate, severe. We have the Japanese criteria also, where more than one, they have different types of aneurysm. It may be a uniform dilatation or ectasia of the entire coronary. It may be a fusiform aneurysm, and all those things may be there. There may be, you have to find out the Z-scores. Measure the coronary arteries inner diameter to inner diameter, and put the height and weight, and then calculate the body surface area and calculate with the standard Z-scores. So anything between 3 to 5 would be a mild aneurysm, 5 to 10 would be a moderate, above 10 or absolute value more than 8 would be a giant aneurysm. Between 2 to 3 will be a mild dilatation or ectasia. So I think the point you wanted to make is that there is a gray area in any viral infection where we have mild, even in dengue cases, and so we have found mild dilatation or ectasia of the coronary arteries, along with slight pericardial effusion, mild valvular regurgitation. So it is those gray areas we cannot pinpoint, and we have to depend on the clinical features, like the platelet counts, the total count, any rash or anything, those things. And of course, we have to temporarily follow it up and repeat the echo and see.
What is the level of anti-proBNP in your
500s. 500.
So we wish we could ask more questions, but time won't permit. Thank you, Debadatta, for a beautiful presentation and innovative ideas.
Thank you.
And let's give her a big hand.